So the purpose of this short presentation is to give the student a brief overview of heparin-induced thrombocytopenia. The objectives that we will cover on this section are to identify the difference between heparin-induced and heparin-associated thrombocytopenia, provide some guidance on assessment of at-risk patients, and then develop an evidence-based treatment plan. One of the things that is crucial to the understanding of heparin-induced thrombocytopenia is recognizing that it is an immune-mediated phenomenon. In contrast to many thrombocytopenias, which predispose the patient to bleeding, heparin-induced thrombocytopenia actually increases the risk of thrombosis. And I'll talk about this and hopefully show you some illustrations that will show you why that's the case in this particular disorder. Also, I'll point out that bovine unfractionated heparin is more likely to cause this disorder than porcine for heparin, which is primarily what is used in the United States. And then that is more likely than low molecular weight heparin. So with the advent of low molecular weight heparins 20 years ago, what we've seen is a decline overall in the incidence of heparin-induced thrombocytopenia. The patients at the highest risk are post-surgery patients, specifically those that get large doses of heparin during their procedure, such as patients who are undergoing coronary artery bypass grafting or CABG, or what many students may think of in the term as open heart surgery. Those patients get large doses of heparin intraoperatively. The larger the dose of heparin, typically the more the likelihood that patients will develop heparin-induced thrombocytopenia, although that's not always the case from an immune reconstitution standpoint. That's what we see borne out in the reported literature. Okay, so heparin-associated thrombocytopenia, in contrast to HIT, is a mild thrombocytopenia that's more due to either underlying disease or a response to heparin, but it's not antibody mediated. So that's a clear differentiation. Heparin-associated thrombocytopenia is not immune mediated. There are no heparin antibodies present, and this is actually not uncommon in hospitalized patients who are very sick and very ill. Now, it's important that if you identify heparin-associated thrombocytopenia, these patients are not labeled with HIT. The reason is because it could predispose the patients to either not be eligible for or to be eligible for heparin therapy in the future. Looking at the pathophysiology of heparin-induced thrombocytopenia, this figure is taken from a journal of Chest from about a decade ago, with the intent, there was a supplement with the intent of providing some guidance on the identification and treatment of heparin-induced thrombocytopenia. What I'll point out here is that in the first stage, you'll see that platelets are activated and there's release of a substance called platelet factor 4 when platelets are activated. You'll also see these are released from granules inside the platelet. So the granules inside the platelet release platelet factor 4. Platelet factor 4 will then bind to other platelets via receptors on the platelet surface. Then, in the presence of heparin, what you sometimes see is a bundling or a binding of platelet factor 4 heparin complexes. And so here these platelet factor 4 is illustrated by these figures here, and the heparin molecule is illustrated by the thread-like diagram, and sometimes you'll see these in pairs, so bundling of 4 or 8 of those together. These are bundles of 4, a bundle of 8. If you'll go to the next step, so right, and then move to the bottom, what you'll see here are these platelet factor 4 complexes that are cross-linked or bound to antibodies to heparin platelet factor 4 complexes. So when we talk about a HIT antibody, a heparin-induced thrombocytopenia antibody, what we're talking about is an antibody that is targeted to platelet factor 4 and platelet factor 4 heparin bundles. Now, in the presence of those platelet factor 4 heparin bundles linked to HIT antibodies, it elicits an intense amplification of platelet activation. So as we move to the left now on the bottom, in this bottom middle diagram, what you're seeing here are these heparin platelet factor 4 antibody complexes cross-linking platelets to one another. Platelets cross-linked by platelet factor 4 heparin antibody complexes undergo an intense activation as illustrated by the morphology that's depicted here in this diagram. The result of that are release of microparticles full of substances such as cytokines and other activating agents that result in even more profound platelet activation. So I'm going to change slides, and this is taken from the same issue of that chest supplement, and this is an actual diagram. This is an image of, here in panel A normal platelet, non-activated platelet, in B a platelet activated from a patient suffering with HIT. And so what you'll note is the significant morphologic change that has taken place in this diagram, and then zoomed in on that image is the microparticles being released from the platelets. So you can see here with this this picture of an activated platelet in a patient suffering from HIT, the extreme amplification and activation that the patient's platelets undergo when they suffer from heparin-induced thrombocytopenia. So when we're looking at patients and evaluating patients that may have this disorder, it's extremely important that the clinician remember that this is not solely a clinical diagnosis, nor is it solely a laboratory diagnosis. I've heard the term that it is a clinicopathologic syndrome, which means that you need both the laboratory findings and clinical features in order for the patient to be diagnosed with this disorder. Typically, patients are screened with an ELISA test, or enzyme-linked immunosorbent assay, and that is a fairly easy assay that can be done at most hospitals. It may not be done immediately, but oftentimes done overnight, so it's very easy to get that test. In contrast to that, the SRA, or serotonin release assay, is the recommended confirmatory test. The problem with the serotonin release assay is it's a little more time intensive, and it's more manipulative from a technical standpoint, so a lab technician has to do more work in order to be able to do an SRA or a serotonin release assay. So the guidelines recommend that an ELISA is used to screen and an SRA is used to confirm. So in best practices, if a patient tests positive with an ELISA, then that should be confirmed with an SRA. The problem is, at our facilities here and at many facilities across the country, while the ELISA is an in-house test, the SRA is a send-out test, and it may or may not be readily available for clinicians to make quick decisions. However, if you're going to commit a patient to treatment for HIT, it is not unreasonable to send out an SRA and confirm that the patient does truly have heparin-induced thrombocytopenia. Now, from a thrombocytopenia standpoint, by definition, platelets should drop greater than, it actually shows less than there on the slide, that's a typo, it should be greater than or equal to 50% from baseline. The 90% of patients, their platelet count is going to be between 15 and 150,000. So almost all patients are going to be less than the primary cutoff for thrombocytopenia, which is 150,000 platelet count, with a median platelet count of 50 to 60. This is also, when you're dealing with HIT, a rapid onset disorder. It typically happens quickly over a few days. It can occur extremely rapidly, and this would be considered a rapid onset HIT over 1 to 2 days, or it could also be a delayed onset. But typical onset is going to be fairly quick, over 5 to 10 days, with a more rapid onset over 1 to 2 days. And the rapid onset primarily is going to be seen in patients who have been exposed to heparin previously. For the purposes of the information we're talking about here for this course, you won't need to worry about delayed onset. From a typical HIT presentation, the key things, and so this is illustrative of what you might see when reviewing a patient's chart, is a patient has a normal platelet count over a period of time. So here at about 3.5 days, so somewhere around 190 to 100 hours, we see a sharp, drastic decline in platelet count from around 215,000 to less than 100,000. We'll say 90,000. That happened in less than 1 day. That is typically how patients with true HIT will present. You'll see a very modest decline with a sharp, drastic decrease in their platelet count. There will be a nadir, which is the lowest platelet count that is measured, and then there'll be somewhat of a plateau where the platelet count either stays the same or maybe slowly increases over a period of a few days, and then the patient's platelet count will begin to recover back to baseline. So that would be a typical heparin-induced thrombocytopenia presentation. In contrast, when we think about heparin-associated thrombocytopenia, the typical presentation for that from a platelet count standpoint is that patients will come in with a baseline platelet count that's normal. Over time, that will decrease, and as you notice here, the line goes down slowly over a period of about a week or so, and while the platelet count does nadir around 100,000, maybe even lower than 100,000. The point would be that you don't see this sharp, drastic decrease overnight in the patient's platelet count. When you're looking at your trend, what you'll see is it's a slow decrease over time. Typically, these patients are going to be chronically ill, oftentimes in the ICU, maybe with sepsis or some other reason for them to develop thrombocytopenia, but oftentimes it's going to be attributed to receiving a heparin product. In patients with HAT, remember that you don't have to discontinue heparin products. In a patient with HIT, heparin-induced thrombocytopenia, you absolutely have to discontinue heparin products. So these are the two overlaid together, heparin-induced and heparin-associated thrombocytopenia. Again, notice here in the yellow line that what you see with HIT is, again, you'll see a sharp decline quickly, whereas with heparin-associated thrombocytopenia, you'll see a slow, steady decline over time. So for those patients that do have heparin-induced thrombocytopenia, acutely, the primary treatment is stop all heparin products. Next, and just as importantly, it is imperative that the patient be treated with an anticoagulant. The only studied and approved anticoagulants for the acute treatment of heparin-induced thrombocytopenia are the direct thrombin inhibitors, specifically only argatroban. So you know that dabigatran is a new oral direct thrombin inhibitor. It's not studied and not indicated for this disorder. Bivalirudin is another direct thrombin inhibitor, again injectable but not studied for this disorder. Argatroban is the only agent approved that has solid evidence for the treatment of acute heparin-induced thrombocytopenia. Key points about the drug argatroban is that it's hepatically metabolized. It's dosed based on the activated partial thromboplastin time, just like heparin. It does, however, prolong the prothrombin time, and we will talk about the challenges in bridging a patient from argatroban to warfarin in a few moments. The other thing I'd point out is that the agent fondaparinux, which is a synthetic pentasaccharide, it's synonymous to the pentasaccharide complex on low molecular weight heparin that binds to factor 10A via antithrombin. Fondaparinux is not a heparin product, even though that it is an analog of a heparin product. It is, in fact, safe to use fondaparinux in patients with HIT. However, it's not endorsed for the treatment of acute HIT. It is likely a good option in patients that have a remote history of heparin-induced thrombocytopenia. So fondaparinux can be used, but it's not to be used as the first-line agent of treatment for patients with HIT. Again, the treatment discontinue all heparin products, and this should be they should be avoided completely for 6 months. In patients who've been over 6 months with a negative HIT antibody test, they can be re-challenged with a heparin product after that period of time. Now, the key thing to differentiate is, did the patient experience a thrombotic event or not, yes or no? If the patient did not experience a thrombotic event, then we treat the patient with a direct thrombin inhibitor until the platelets are greater than 150,000. We will monitor them for thrombosis during that period of time, but long-term anticoagulation with warfarin or any other oral agent is not necessary if the patient is without thrombosis. However, if the patient does experience a thrombotic event during the course of their heparin-induced thrombocytopenia, then we're still going to treat them with argatroban. We're not going to give them a heparin product, and then we're going to treat that VTE, or in some cases an arterial clot. We're going to treat that with an anticoagulant just like we would treat any other venous thromboembolic event. So we could use any agent, of course, except a heparin product for treatment once HIT is resolved. Now, one key thing, if we chose to use a vitamin K antagonist instead of one of the new oral agents on the market or fondaparinux for long-term treatment of the thrombotic event in those patients, it's a little tricky because we don't want patients with acute HIT on a vitamin K antagonist. I won't go into a lot of details, but just think back to how warfarin works. HIT in and of itself, through platelet activation, generates an intense amount of prothrombin, which is then converted into thrombin. At the same time, if we're giving a patient a vitamin K antagonist, which greatly depletes their protein C within a number of hours, but has no effect on prothrombin for a period of up to 4 or 5 days, what we're doing is putting that patient at risk for an acute thrombotic event. So, in patients with acute HIT, they should not be on a vitamin K antagonist, and in fact, if they have been on a vitamin K antagonist, let's say we started one a few hours before we realized they had HIT, or within the last day or so, then what we want to do is give that patient vitamin K to reverse the effects of warfarin so that the patient can mount an appropriate response with protein C and protein S. So they'll use that substrate to produce protein C and protein S to balance out this intense overactivation of the clotting cascade. Now, in the patient who has recovered their platelet count, so they no longer have thrombocytopenia and the acute HIT is resolved, but they have a venous thromboembolism and we want to treat them with warfarin, then we will need to bridge that patient to warfarin therapy with the argatroban that they're on. The problem with argatroban is argatroban prolongs the prothrombin time and roughly doubles the INR. So that means that for a patient with an INR range of 2 to 3, with argatroban therapy on board, we will titrate that INR to a range of approximately 4 to 6. Then what we will do is DC the argatroban and we will recheck that INR after 4 to 6 hours off of argatroban therapy. This will give us the underlying INR of that patient. If the INR is less than the goal of 2, so we want a therapeutic range of 2 to 3, if the INR has not achieved that therapeutic range, we will then restart argatroban and recheck that INR the next day for that patient. If the INR is at goal, and the patient has been bridged adequately for 3 to 5 days of overlap with argatroban and warfarin therapy, then we can discontinue the argatroban at that point in time and we'll continue with warfarin monotherapy, just like we would if the patient was being bridged with unfractionated heparin. So in summary, that is the conclusion of the topic of heparin-induced thrombocytopenia. Key take-home points would be that it's immune-mediated, it's a thrombotic disorder, not a thrombophilic disorder, a hemophilic disorder. It is treated with a direct thrombin inhibitor. Heparin products should be avoided. And also remember the acute drop in presentation. Go back to those graphs, HIT versus HAT. This is much less common in 2016 than it was even a decade ago, and particularly 2 decades ago with the advent of low molecular weight heparins in the mid-1990s, as low molecular weight heparin has a much lower instance of heparin-induced thrombocytopenia than unfractionated heparin. I hope this was helpful to your understanding of heparin-induced thrombocytopenia.